Thank you so much for everyone being here today. I think we have people from all time zones, so afternoon to evening. And I've got some green slides for you all to celebrate St. Patrick's Day this weekend. So I'm excited to talk with you all about some updates in constipation management. And I am currently practicing as a pharmacist in the adult cystic fibrosis clinic at the University of Kentucky in Lexington. I don't have any conflicts of interest related to the content today, but just as a disclaimer, nothing that I say today should necessarily be considered medical advice, and you should always talk with your CF team before making any changes to your treatment plan. But if you hear something today that you think might help you, I would encourage you to discuss these topics with your team and see if it's something that you should try. So a little bit about me. I am originally from Central Illinois. I was born and raised in Decatur, and I went to undergrad in pharmacy school in Southern Illinois at Southern Illinois University, Edwardsville. Then after that, I hopped one state over to Indiana, where I completed 2 years of pharmacy residency at Indiana University. And I've been here in my current job ever since I finished residency, which is almost 7 years now. I do have a passion for learning about and advocating for CF, and this started early on because growing up, one of my closest family friends, she has CF. She was born 10 days before me, and we were pretty much attached at the hip growing up. So I learned from a pretty young age about CF and the shaky vest and all of these things. And I never really expected it to turn into something that could be a career for me, but I got really lucky, and the perfect dream job, outpatient pharmacy in a clinic with adults with CF, came up. And so it's been pretty serendipitous with me to end up here, since it has been something I've been passionate about since childhood. So 3 main things that I hope to cover today. I do want to review these newer medicines that we're using for treatment of chronic constipation. And I want to go over some of the existing data for these agents, specifically in people with cystic fibrosis. You'll see there's not a ton of data that's currently published, but I am excited to share with you kind of a first look at some data from a study that I have been doing with one of my colleagues in Utah that's currently pending publication, that will hopefully expand our database of what we know about some of these medicines in CF. So I'm really excited to be sharing that for the first time with you all today. Just for a little bit of background, constipation is a common complication of cystic fibrosis, and studies have estimated anywhere from 42 to up to 73% of people with CF will experience constipation, and this does go up as we age. So we know that it becomes more prevalent as people with CF are aging. And historically, there wasn't really a great definition of what was constipation in CF. We knew about DIOS, distal intestinal obstructive syndrome, but constipation was one of those topics that we didn't know exactly how to define it, with so many other things going on in the GI tract. So in 2005, there was a work group that got together and said, we really need to define constipation. We need to make some recommendations of standards around CF constipation. And so the definition that they came up with included a combination of symptoms, and those symptoms must be relieved by the use of laxatives. So the symptoms included abdominal pain or distension, which is kind of that bloating or expansion of the belly when you're experiencing constipation. And that had to be accompanied by either a decline in the frequency of bowel movements over the past weeks to months, or an increase in consistency of those stools, so thicker, kind of harder to move. And again, those symptoms had to be relieved by the use of laxatives. As far as what causes constipation in CF, one of the reasons that it is difficult to target is because there are so many different factors that could be contributing to constipation. We know that the small intestine transit is slower in people with CF, so those muscles that contract to help push contents through the colon are a little bit slower, and so that does cause that feeling of constipation or being backed up. We know that thick, sticky mucus that's present in other organs is in the intestines, and so that altered composition of the intestinal contents makes it harder for the contents in the intestines to move throughout the GI tract. So we have slower movement anyway, and then we're also making the contents thicker, so it's kind of a double whammy, which contributes to constipation. Altered pH and also gut microbiome, which has been a pretty hot topic in recent years. Microbiome is that composition of good bacteria that lives in the GI tract, and we know that in people with CF, there tends to be less diversity in those good bacteria, and we think that can contribute to a lot of GI symptoms such as constipation. And then, of course, the crux of it all with CF, those little chloride channels that are not working cause this abnormal electrolyte and water transport. And so we know that if we can't get enough chloride into the intestines, we don't get enough sodium. That sodium chloride or salt is what helps pull more water into the intestine to make the contents more fluid and able to move. So just like it's causing those changes in the lungs, in the pancreas, all over the rest of the body, we see that same issue in the colon, in the GI tract. So historically, we've been pretty limited on what options we can use to treat CF, and we're still using all of these things today, but we're lucky that we've made a few more advances in recent decades. So we have our polyethylene glycol, or PEG, which you may know as Miralax, is one of our main constipation management options, as well as non-stimulant stool softeners like Docusate to help soften the stool. We promote hydration and regular exercise, as we know that both of these can help to relieve constipation symptoms, and slowly and safely increasing fiber in your diet has also been suggested. Unfortunately, increasing fiber too quick can cause constipation, so it's sort of a delicate balance when it comes to dietary fiber. But we have these options as well as some stimulant laxatives like Senna and Dulcolax, but overall pretty limited in what options we've been able to use. So it's been interesting to see over the past couple decades some emerging therapies for constipation that we have as options now. So we'll talk about two of these categories. We'll talk about the intestinal secretagogues, which are made up of chloride channel activators and GCC agonists, which we'll talk about what those mean and how those work. But those agents tend to be more locally acting in the GI tract, so you don't absorb them into your bloodstream, which typically means we can expect less side effects, which is a good thing overall. We have less interactions with medicines, less side effects to worry about. And then we have our serotonin type 4 agonist that we'll talk about. That one does get absorbed into the bloodstream, so we can talk about what that means as far as using it as a therapy. And then some agents that we won't necessarily talk about, but you may see be used even in CF constipation, are opioid antagonists. We know that opioid pain medicines can cause constipation, and that has its own mechanism. And so these agents can be used to target constipation that's caused by needing those chronic opioid pain medications. So we'll start with these intestinal secretagogues. We have three options: lubiprostone, linaclotide, and plecanatide. And you know, to be unbiased, we always, as pharmacists, talk about medicines as their generic names, but I will tell you their name brands too when we get to each individual slide. So you may recognize some of those by their brand names. I know this is very sciencey, probably taking you back to biology classes, but this is a little cartoon image of a cell in the colon. So we have epithelial cells which line the colon, and the intestinal lumen would be inside the GI tract where the stool contents would be. The submucosa is the outside of the intestine. And we have these different types of chloride channels that are acting right there in the colon. So lubiprostone acts on these type 2 chloride channels, and they help to open these chloride channels to activate chloride flowing through into the intestinal lumen, into the GI tract. That in turn, we know pulls in extra sodium, which pulls in water, which can help to improve the consistency of the stool contents in the GI tract. Similarly, we have they're called GCC agonists. So these two agents, linaclotide and plecanatide, act on this receptor called the guanylate cyclase type C receptor. And what that receptor does is it changes this signaling protein called GTP in the body to change to cyclic GMP. So what that means is cyclic GMP is a substance that goes to these CFTR channels that are along the lining of the intestinal lumen, and they activate the CFTR chloride channels to allow more chloride to pass through into the intestine. It also has an added benefit of binding to pain fibers in the GI tract. So these agents are expected to downregulate pain, the abdominal pain associated with constipation. So a lot of people, when they're experiencing constipation, are also experiencing abdominal pain. So this can address some of that abdominal pain as well. But with all of these agents, the net benefit is that we get more chloride into the intestinal lumen. For a long time, we thought that it wasn't a good idea to use these agents that act directly on the CFTR channels, because we know that with some mutations, those CFTR channels are not even present on the cell surface. So for a long time, the focus was more on lubiprostone, which acted on these other types of chloride channels. But now, as we know, we have more treatments in our CFTR modulators that are helping to put the CFTR channels where they need to be on the surface of the cell. So in more recent years, especially with the advent of triple therapy, we have wondered maybe there is more of a place in therapy for using things like linaclotide and plecanatide. So I'll try not to bore you too much with the science. We'll go back to talking more about each individual medicine. So the first one, lubiprostone, was originally approved by the FDA in 2006 under the brand name Amitiza. And so it has been around a little bit longer and is approved for chronic constipation as well as irritable bowel syndrome with constipation. We have a couple of different dosage forms. We have an 8 microgram and 24 microgram capsule, and it is recommended to be taken with food and water, and it's dosed twice a day. Like I mentioned before, if not well absorbed into the bloodstream, it has more of a localized effect. So typically this is a good thing, especially if you're on multiple medicines. It reduces the risk typically of side effects and of drug interactions. So we always like to see something working at the site where it needs to get to. With that comes side effects that are more associated with the GI tract. So the most common side effect, far and above, is nausea. And this is from some of the clinical trials that were performed. And now this is not specifically in people with CF. This is in the population with chronic constipation and irritable bowel syndrome who were originally studied. I always like when I can see the rate of a side effect in a placebo group, because we know the placebo group didn't have any of the medicine. And so sometimes just from having a GI related illness, some of these side effects may be present. And so I always like to be able to compare to that placebo group who had no medicine. And so you can see the second column here shows people on the lower dose at 8 micrograms. And the third column is the patients on 24 micrograms. And nausea was very common. 29% of people in this 24 microgram capsule group experienced nausea. And of those 29, with that 29%, 9% of the total patients did have to stop therapy because of nausea. So this is a significant side effect. And it tends to be worse earlier on in therapy. For most people, it improves as you're taking the medicine. But for some people, it never goes away. So it can be a limiting side effect that makes people have to stop. The next most common side effect that was seen in clinical trials was diarrhea. So we're making the GI tract work a little bit better. And in some cases, maybe it's working too fast or pulling too much salt and water into the GI tract, and that can result in some diarrhea. 11% of patients in the 24 microgram group did report headache. Headache is a really hard side effect. I always say it's a side effect of pretty much every medicine that exists, and it's really hard to know why that's happening. But it was reported in more than 10% of patients. So it is something I like to educate people about when they're going to start this medicine. And then other GI-related side effects that we're seeing in lower amounts, but still greater than 5% of the population, were abdominal pain, abdominal distension or bloating, and flatulence or farting. And so most of the side effects you see are happening directly from the GI tract because of that activity in the GI tract. Most of my patients, when I'm talking to them about having chronic constipation and I tell them they might have diarrhea, they tell me, that sounds great. I would take diarrhea over having constipation any day. But it is important to note that some people do get severe diarrhea and are unable to take this medicine. So luckily now we have some of these other options like linaclotide, which was approved later by the FDA in 2012 under the brand name Linzess. And it has the same indications for chronic constipation and irritable bowel syndrome, and is available in 3 dosage forms, which I appreciate because it gives us a little more flexibility if patients do have side effects or if they're not having benefits from therapy, we have more options to use. The nice thing about linaclotide is that it is dosed once a day, so a little bit easier than a twice a day treatment, but it does need to be taken 30 minutes prior to the first meal of the day. And people who take linaclotide and drink coffee right away often experience more side effects of diarrhea. So it is important to try to take it 30 minutes before any meal or any coffee or other caffeine sources. And again, it's not well absorbed, so that's a good factor for this medicine for side effects and interactions. The 3 side effects that were reported in more than 5% of the population for each dosage form or for each dose studied were diarrhea, abdominal pain, and flatulence. So diarrhea was the most common, and in our 145 microgram group, which is that middle dose, it's usually where we're starting out, at least in my clinic, 16% of people experience that diarrhea. And less discontinuation here, only 2% of the total population had to stop therapy due to diarrhea in that 72 microgram group, and anywhere from 3 to 5%, depending on which studies you look at, in that higher 145 microgram group had to stop, but definitely lower incidence of that main side effect than what we saw with the lubiprostone or Amitiza. And then plecanatide, which is available under the brand name Trulance, was approved in 2017, again with the same indications. We have a little less dosing flexibility here because it's only available as a 3 milligram tablet, but it can be taken with or without food and is just once a day. And again, not absorbed into the bloodstream. The only side effect that occurred with plecanatide in 5% or more of patients was diarrhea. So we saw with this one a little less side effects as far as GI-related side effects. And with the 5% who did report diarrhea, a total of 2% of the patients did have to stop therapy due to that side effect. So this one may have a little bit friendlier of a side effect profile, but it is newer. So sometimes a newer agent is harder to get covered by insurance, just depending on specific insurance plans. So we haven't seen this one quite as much, but we're starting to see it a little more now that it's been out for a while. So those are our 3 options that are working locally in the GI tract. We have one option that is a type 4 serotonin antagonist. So 5-HT is an abbreviation for serotonin. And we have these type 4 serotonin receptors in the GI tract. So there are 7 different types of serotonin receptors all throughout the body. We're most aware of the receptors that can impact mood, depression, sleep and appetite, some of those things that we're using serotonin agents for more commonly. But we also see serotonin receptors in the GI tract. We see them affecting muscle contraction, including cardiac or heart function. So the contraction of the heart can be impacted by certain serotonin receptors. So they're all over the body. And this agent, prutalipide, has been studied to specifically target the 5-HT4 in the GI tract. So we're specific to the GI tract. So it is highly selective for the GI tract receptors. And this is important because there was a medicine that was approved for constipation that was removed from the market because they found that while it did improve the serotonin type 4 receptor function in the GI tract, it also had negative side effects on some of the other serotonin receptors. Specifically, patients were experiencing increased cardiovascular events, so heart attacks and things like that. So it was pulled from the market. So when this came out, a lot of people were skeptical because they wanted to see that this would be highly specific to the correct serotonin receptor. And when we target that correct serotonin type 4 receptor, we see what's called prokinetic activity. So what that means is the medicine binds to the receptor. It releases or activates these excitatory neurons. So these nerves are responsible for releasing a substance called acetylcholine. And that acetylcholine is what actually triggers muscle cells to contract. And so it goes to these smooth muscle cells that are the types of muscles that are all along the colon in the GI tract. It causes them to contract, and that contraction in the GI tract is what helps move contents through the colon. And so this is acting on the GI tract, but it's absorbed into the bloodstream because it's getting absorbed and then impacting that muscular signaling system. So prucalopride was approved by the FDA in 2018 under the brand name Motegrity. And it's available in 2 dosage forms, a 1 milligram and a 2 milligram tablet. And it can be taken with or without food once a day. But it does readily pass into the bloodstream. So what this means is we have to be more aware of drug interactions, and there can be some side effects that can occur. But we do know it's highly selective for the right type of serotonin receptor that we want to target. So that is a lot better than some of our previous similar agents. The most common side effect here was headache. You can see headache occurred in 9% of people who were on placebo in the studies. And for people on 2 milligram tablets, 19% of people experienced headache. So there was 10% more incidence of headache in that treatment group. And we do know that, maybe even though they're highly selective, maybe there is some activity on the serotonin receptors in the brain that's causing that headache. We're not positive about that, but that could be one of the causes of that headache. Other common side effects that occurred were abdominal pain, nausea, and diarrhea, which all did happen in more than 10% of patients. And 10% is sort of the threshold that we look at to say it's a common side effect if it occurs in 10% or more of patients. So these are things that I like people to be aware of before they start this medicine, because they are likely to experience some of these, especially in the beginning of therapy. About 2% of people stopped due to any side effect. So not an extremely high discontinuation rate here, but we do have pretty common occurrence of side effects. So now that we understand some of the basics of how these medicines work, I want to talk with you all about use specifically in people with CF, because we know that just because something works for one person with constipation, it may not work for another person with constipation. And the causes of constipation, especially in CF, are so different than other populations. So as a little foreshadowing to what you'll see, data has been limited, but we are using these agents more frequently. So I think it's important that we build this information out. We need to see more publications about these agents, which is why I've been working a lot on this topic, and excited to share some of my research with you. But lubiprostone, like I mentioned, the Amitiza, that's the agent that was really first studied. And that was because a lot of this happened before we had widespread use of modulators in most people. And so we thought we needed to target this type 2 chloride channel rather than targeting the CFTR chloride channel in the GI tract. And so one study group looked at 3 patients that they had put on lubiprostone, and they published information about these cases to try to get others to see that there is a possible place in therapy. This group, led by investigator O'Brien, said that because it activates a chloride channel other than the CFTR channel, they expected that lubiprostone could address underlying factors of constipation in the CF population. And so they told us about 3 patients, a 34-year-old female, a 22-year-old female, and a 22-year-old male who utilized these agents. Our first patient, our 34-year-old female, had a past medical history of CF, chronic constipation, and hypothyroidism. And at baseline, she was using Miralax twice a day for her constipation. The team started her on 24 micrograms twice a day of lubiprostone. And they monitored her for 19 months after starting. And at her first 3 visits at 4, 7, and 10 months, she reported taking her Miralax and her lubiprostone or Amitiza as prescribed. And she reported having daily bowel movements and no symptoms of constipation. On exam, her physician determined that there was no palpable stool that they could feel when pushing on her belly. At 14 months, she came back to clinic and she was still taking her Miralax, but she reported that she started taking the lubiprostone as needed due to having some loose stools. But she still said she had good control of her constipation overall, so she was happy with that. And there was, again, no palpable stool on physical exam. At 19 months, she came back. She had completely stopped the lubiprostone at this point. She was still taking her Miralax as prescribed. She denied feeling like she had symptoms of constipation, but when her physician performed physical exam, they did feel that it felt like she had stool burden in her GI tract. So they instructed her to restart the lubiprostone 24 micrograms twice a day at that point. And that's the point at which this was published. So we don't have follow-up on whether she tolerated after that. However, during the duration of use, there were no concerning changes to her blood test, to her lung function, or her weight. And so there was some promise that it looks like it's safe. Does it work? We still need more info on. We know that there's possibility of side effects with her experiencing loose stool, but overall no concerning safety issues. Our second patient was a 22-year-old female with cystic fibrosis, chronic constipation. She actually had a history of more severe constipation causing distal intestinal obstructive syndrome, or DIOS. She was pancreatic insufficient, had depression and attention deficit disorder, and at baseline did complain of nausea, which, as you'll remember, is a side effect of lubiprostone. So the team wanted to be really careful to follow this side effect if that worsened for her. She was on Miralax twice daily at baseline. And she was actually initiated on the lubiprostone because she had an admission for an obstruction. After that obstruction was resolved, she was sent home and started on lubiprostone treatment. And they did also at this time increase her Miralax to 3 times a day to try to make sure that they're preventing any future hospitalization or recurrence of that obstruction. She had 8 visits over the first year of being on lubiprostone, and she did report constipation on 2 of those 8 visits, but she had also said at those 2 visits that she had not been taking her Miralax regularly. And she did report nausea at 6 out of the 8 visits. However, she did not report that the nausea was worse than baseline at those visits. At 16 months, post-initiation, she did have some increased abdominal pain and was started on some opioids, which in turn could worsen her constipation. She had a decline in her nutritional status and ended up having to have a feeding tube placed. The team noted that malnutrition had been something she suffered with even from baseline, so they didn't expect that this was caused by the lubiprostone, but nonetheless, she did have to have that G-tube placed, which along with it, she kept reporting abdominal pain, as you can expect from any procedure where you're going into the GI tract. She did deny symptoms of constipation, however, despite not taking her Miralax, but she did have to have more frequent use of some opioid medicines to treat her pain. So about a half a month after initiation, or 17 and a half months after initiation, half a month after the G-tube placement, she was admitted for severe constipation that was not responding to treatment. And she ended up being continued on her lubiprostone and Miralax, but also started on one of these agents that can be used for opioid constipation. So a little more complicated of a case for our second patient. Our third patient was a 22-year-old male who had cystic fibrosis, intermittent constipation rather than chronic. So he had issues here and there, but overall didn't have chronic problems. He did have pancreatic insufficiency and malnutrition. Since his constipation was intermittent, he wasn't on any regular bowel regimen at baseline. But the reason that he was started on treatment was because he did have a hospitalization for an obstruction. And when he followed up in clinic about 1.5 months later, he was very concerned about trying to start something that could prevent another hospitalization. So the team decided to start him on lubiprostone, 24 micrograms twice a day. And at 6 months post-initiation, he was taking it as prescribed and denied any symptoms of constipation. At 16 months after starting, he said he was taking it about 2 to 3 times per week, and he felt like he didn't need it every day because he had such good control of his constipation symptoms. He never reported any nausea, and he hadn't had any subsequent obstruction events. And again, in this case, he didn't have any concerning safety side effects, any changes to blood labs, weight, or lung function. And so although a very small study with only 3 people, the authors concluded that with a mean duration of treatment of about 17 months at the time of publication, they could say that there is maybe benefit to using lubiprostone in people with CF-related constipation, but there's a lot of uncertainty about whether combination therapy is required. So do patients still need to continue their Miralax and other bowel regimens that they're on? That's still a big question that we need to answer. And it seems to be different from my practice experience from patient to patient. Some people will be able to stop other treatments. Some people need to continue just depending on severity of their constipation. None of the patients reported unexpected adverse events. And the one patient who had nausea had that chronic nausea at baseline and symptoms were not reported to be worse. So that was promising that of these 3 patients, we would have expected one with that 30% incidence, one of those patients we would have expected to have nausea. And so the question was, maybe that side effect in practice is not as common as we think, or maybe it's not as common in people with CF as it was in the general population. And while each different patient's course did vary, some of them continued taking it, some of them kind of stopped taking it altogether, some took more as needed, which isn't really well studied. At some point in treatment, all the patients did report some improvement. So while it seems like this is not a lot, this was the only data we had at the time. And the same group decided that they wanted to try to collect more data. And instead of going back and collecting information after the fact, as with the first study, they wanted to look at what happens if we follow people right when we start them on lubiprostone and follow them forward. Maybe we can get more specific information. So it was just a little bit more of a structured interventional type study. And this included still a small population of patients. They had 7 patients from a single center. And the patients that they included had to be 18 years or older with CF and constipation, with scheduled doses of laxatives. And they looked at a couple different scores. One of these is the PACSIM, or Patient Assessment of Constipation Symptoms, which is a survey that you would take that would ask questions about abdominal pain, stool frequency, stool consistency, different variety of symptoms that go along with constipation. And then the other one they looked at was the Bristol Stool Scale. So that's the scale that you may have seen pictures of it if you've been to a GI clinic, but it identifies the texture of your stool with a smaller number, meaning harder stools, more constipation is likely present, all the way up to essentially diarrhea. Exclusion criteria included, they didn't want to include people with recent or current obstruction, so anyone with a current or obstruction within 6 months. People who are pregnant or breastfeeding were excluded because it's not studied, so we don't know about the safety profile in this population, as well as anyone who had any kidney or liver abnormalities. They also excluded patients with lower lung function, so people with lung function less than 40 were not included here. And people with frequent exacerbations, pulmonary exacerbations were excluded, as well as those who were currently listed for lung transplantation. But they were able to collect data on 7 patients with an average age of 26 years. About 42.9% of the patients were male, with an average BMI of 24, which is within our goal range. The average lung function by FEV1% predicted was 83%. And at baseline, patients had varying treatments for their constipation. So three of the patients were on scheduled Miralax alone. 2 of the patients used scheduled Miralax plus milk of magnesia. 1 patient was using Senna tablets as needed, a stimulant laxative. And 1 patient actually had already been on lubiprostone, but they decided to include them in the study because they had not been on it for very long. So what they did is they did a 2-week period where they asked all the patients to continue their current regimens and be as adherent to their treatments as possible. And then for 4 weeks, they followed up with these patients to put them on lubiprostone 24 micrograms twice a day with meals. And they did include the option to decrease to once a day if patients had nausea that was intolerable. And their primary outcome that they looked at was the change in number of bowel movements per week. And this was just logged. All the patients kept diaries of their constipation symptoms. And so that's how they tracked that primary outcome. But they did continue to monitor those 2 surveys I talked about, the PACSIM and the Bristol Stool Scale. And they also looked at adherence by counting the patient's pills at weeks 2 and 4 to see how many doses had been missed. And they collected patient-reported adverse events at 2 and 4 weeks. So what they found was that as far as efficacy, the statistical significance is based off of something called a p-value. And the p-value for the patient-reported stools per week was not statistically significant. So this means that there wasn't a significant difference from baseline in number of stools per week. There was also no reported significance in that Bristol stool scale, which is the stool consistency. But when they looked at this PAC-SIM score, they found that the overall score did show statistical significance. And so we know that this is exactly representative of how the patient's feeling. So this is a really important outcome to have. While the number of bowel movements didn't necessarily change, the overall constipation symptoms were significantly improved. And this was specifically driven by the surveys broken down into 3 categories: abdominal questions, rectal questions, and stool-related questions. And the changes were driven by the abdominal and stool domains of this survey. So what we know from this is that patients did feel better, and that's important when we're thinking about constipation. The other thing that was important was, were people having side effects? And so they saw that nausea was reported for 2 patients total in the study. For one of the patients, by that 4th week check-in, they had said that the nausea was resolved. So for one person, it did resolve, but 4 weeks is a pretty short amount of time to follow. So it's possible that that other patient could have resolved that side effect as well. But 2 out of 8 patients, or about 25%, did experience nausea. And then 1 patient reported any of the other side effects listed here. I won't read through all of them, but most of them are GI in nature, with the exceptions of headache, migraine, insomnia, increased cough, and some chest tightness or shortness of breath. So there's not a lot of data on some of those side effects. I was hoping they would talk more about the patient who had especially this chest tightness and shortness of breath to know was something else going on. Did they have an exacerbation? But since they were reported at all as potential side effects, they did include them here. So it is something for us to consider. I personally haven't seen this in practice, which is promising, but again, not a ton of data published. So the authors concluded here that there were some limitations. They were limited by a short duration and a relatively small sample size. And overall, the population they chose was relatively healthy because, as you remember, they had to have lung function over 40%. They couldn't have frequent exacerbations. So we're really looking at a pretty healthy subset of people here. And we didn't have any type of placebo group for comparison. But they concluded that this lubiprostone or amitiza may be an effective option for treatment of constipation, especially in those who continue to have abdominal type symptoms, despite chronic treatment with other treatment modalities like Armiralax. So they wanted to see further studies, which, with such a small number of patients makes sense. That's where, unfortunately, our lubiprostone data ends. We have even more limited data for our other agents. Linaclotide has 1 small animal study that's been published. And what they did in this study is they breed mice to have CF, and then they expose them to these treatments. And they found that in these animal studies, which I'm by no means an expert in animal studies, so this is really the short of it here, they found that there was improved gastrointestinal transit in these mouse models, and increased fluidity of GI content. So the authors concluded here that we really need some studies to assess whether this translates to humans with CF, but that this could be a promising therapeutic target for us. So that is where the data for these new agents ends as far as published data. Now, many of us working in CF clinics have anecdotal data of what we've seen and experienced or what we've heard from other centers who are using these agents, but where do we go? What's next here? There's not a lot published, but many people do seem to be benefiting from these therapies. So it is kind of a disconnect between the scientific literature and what we're actually seeing in practice, because every year I go to conference, I talk to other pharmacists and physicians and other people practicing in CF clinics, and the overarching theme is that people are using all of these agents. So we really need to get more data out there. So I'm excited to share with you some data that I've been working on for the last year or so. This has been a study I've been working on with one of my colleagues in Utah. we are looking at linaclotide or Linzess use in people with CF. And we currently have this submitted for publication. We're awaiting response, keeping our fingers crossed that this would get published, because this would be huge to get some data out there in people with CF with linaclotide. We're really excited to have 39 people to include, which, as far as you can see, compared to what we have, this is a big population that we're able to get data out there on. Our average age has been 35 years at initiation of linaclotide. About 27% of patients were female at birth. And you can see we looked at CFTR mutations. About 21% of patients had 2 copies of Delta F508. 62% had 1 copy of Delta F508 and 1 copy of another mutation. 15% of patients had other rare mutations, and 1 patient did not have any known mutations but was diagnosed with CF. Our average lung function was fairly high at 84% predicted, and 87% of our patients were pancreatic insufficient. We looked at baseline CFTR modulator use because we are curious. We weren't able in the confines of this study to look at it, but we would love to look at if there's changes between efficacy, the effectiveness, or the side effects in people depending on what modulator they're on, or if they're not on a modulator. So we're hoping maybe this is something we can look at in the future. In this study, we had about 18% of patients on no modulator therapy, 5% on ivacaftor or Kalydeco, 2.6% on lumacaftor ivacaftor or Orkambi, 2.6% on tezacaftor ivacaftor, which is Symdeko, and then the overarching agent of use was almost 72% of people on elexacaftor, tezacaftor, ivacaftor, or Trikafta, which is what we expected to see based on just overall use of modulators in the population. One thing we were curious about is what dose were these patients starting at, because there's not a ton of guidance with CF-related constipation and in what dose we should be starting. The majority of patients, 72%, were started on that middle dose, the 145 microgram. This is where I personally like to start because it gives us the flexibility to decrease the dose if there's side effects or increase the dose if it doesn't work. So I like to kind of start right there in the middle. But we do have some patients start at other doses. 18% of people were started on that lower 72 microgram dose. And when we looked at why that dose was selected, the documented reasons in clinical documentation were because of the presence of bloating or because of patient concern for side effects. So if patients were nervous about having diarrhea, which was the most common side effect, we started on that lower dose. And 10% of patients were started on the highest 290 microgram dose, but there wasn't any clinical documentation of why that dose was selected. About 77% of patients, or 30 of the 39 patients, reported no side effects. So that was really promising that most patients didn't have issues with side effects. Of the 23% of patients who did have side effects, which was 9 people, the most common side effects were diarrhea and bloating. We did have 1 patient who reported fatigue. 28% of patients in the study, which was 11 patients, had to have the dose adjusted at some point. Most of those were to increase the dose. So 8 patients of those 11, 73% had to increase dose during the study, and 3 patients, or 27% of the total who required a dose adjustment, required a dose decrease, likely due to side effects. At the time of publication submission, when we stopped collecting this data, 51%, or the majority of patients, were still taking linaclotide. Of the 19 patients who stopped therapy, 33% stopped because they said the medicine didn't work. 22% stopped because of continued side effects. 17% of those 19 patients felt that they no longer needed treatment. Their constipation had been appropriately addressed and they no longer needed it. 17% stopped for unknown reasons or were lost to follow-up, and 11% of patients had to stop because of insurance coverage or cost. So those 11% switched to other agents besides the linaclotide because of their insurance coverage or their copay cost changes. One thing that I was really excited to look at was dios and constipation events. So we looked at these obstruction and constipation events for 1 year before patients started linaclotide, and then total events since starting linaclotide. So for many patients, this was over a 1 year period, the follow-up time. You can see for total events, 54 of people, or 21 patients in the study, had some constipation or diarrhea event that had to be treated within 1 year before starting linaclotide. The majority of these, 67%, were treated outpatient. So maybe we gave them increased Miralax, increased their bowel regimen, but they were able to stay at home for treatment. 33% or 7 patients did require hospitalization for treatment. Now, when we looked at follow-up after patients started linaclotide, we did see a decline here. The total number of events, there were 8 patients, or 21% now, experienced an event since starting. And like I said, for some of these people, this was even more than a year. So pretty impactful changes here. And again, majority of patients, 75% or 6 of the 8 people, were able to be treated at home, with only 2 people needing hospitalization for treatment. So this is promising to show that linaclotide, for those who are able to take it, does seem to have benefit in constipation and diarrhea events. The longest documented use in this study was 58 months, which is about 4.8 years. The average duration was 16 months, so just over 1 year. And when we looked at use of other constipation treatments after the start of linaclotide, we found that 59% of patients reported being able to decrease use of their other bowel regimens, so things like our Miralax and Senna, milk of magnesia, things like that. 26% of patients had no change in use from their baseline. We didn't see any patients require increased use of their bowel regimen, and we did have 15% of patients who were either unknown or lost to follow-up for this matter. So there are obviously limitations. This is still a small sample size, but it is still getting data out there for the potential benefit. And the lower rates of discontinuation due to adverse events are promising. We definitely need larger scale studies and more clinical sites to be able to identify the true place in therapy. But until then, we know that some patients do have benefit, and it seems to be relatively low risk. So if we can possibly improve constipation, this is an option that we readily try in my clinic, and I think other clinics across the country are trying all of these agents as well. So we need to get more data out there. We need to get, while 39 patients is huge compared to what we have, we need more. It's not good enough. So we need to do better to get more data out there, and hopefully we'll see that, since this has been a topic that's come up at the last several NACFCs. I've heard people talking about these new treatments. So I'm hoping that we'll get more information out there, and hopefully this will get published to help support the cause, and maybe encourage other people to publish as well. I do want to say thank you and a shout out to my co-investigator, Holly Ann Jacobs. She is the pharmacist at the University of Utah. I don't know if anybody here is from Utah, but may know Holly Ann, and we did this together. So I could take any questions, comments, concerns, anything you all have to say, anything you're thinking about this topic. Thank you so much for having me.